All right, welcome back and thank you so much for staying with the Morning Cafe. And right about now on Matters Health, we are talking about uterine fibroids. And this is an invasive, something that is quite silent that affects most women. And you know, most women don't even know that they live with fibroids. And to shed more light on this is Dr. Stephen Ngigi, who is a Deputy Director of Medical Services, Murang'a County, as well as Senior Family Medicine Specialist. Karibu sana to studio, and we'll be tackling your questions. So remember to send them in on Facebook and YouTube at TV47 Kenya, and on X at TV47 News KE. We'll be sure to tackle them and as much ground within the time span that we have. So, Dr. Karibu sana to TV47. Happy New Year.
Thank you.
So, if you can set the stage for us, what exactly is fibroids?
Well, fibroids are what we call non-cancerous or benign uterine lesions that will grow within the uterus in women of reproductive age. And we are seeing a trend where more and more women, especially young ones, are developing fibroids. We are also seeing a trend where women who have given birth are also coming later on presenting with uterine fibroids. So it's becoming a common problem in our society. A good number of these women are asymptomatic. About 30% of these women live with these fibroids without knowing they have them. And hopefully when they reach postmenopause, the fibroids tend to regress. Yes.
So what are the symptoms to look out for?
I have just stated that about 30% of women may not have any symptoms, but we have symptoms in about 70% of the women. There are those who present with pelvic symptoms, which includes they might observe a swelling, a palpable swelling in the pelvic or suprapubic region. They might have frequent micturition. They might experience low back pains or low abdominal pains. They might present with constipation. And in rare cases with the pedunculated fibroids, they might have problems with bowel movement, abdominal distension, and even obstruction, intestinal obstruction. But that is rare. Then we have these ones who present with bleeding, which is normally heavy and cyclic, associated with the heavy blood clots. These women tend to be anemic. They will be pale. They tend to have easy fatigability. And in extreme cases where they have severe anemia, which is microcytic hypochromic, they tend to swell their lower limbs, and they might have high output cardiac failure. So that is quite a wide range of presentations. Others will present with the recurrent pregnancy losses, especially those with submucosal uterine fibroids. And some may actually carry a baby, but before term they might lose that baby. They get what we call intrauterine fetal demise. Sometimes this fibroid is also competing with the baby for nourishment and space. So you end up with a child a baby, intrauterine fetal growth retardation, smaller baby compared to the term baby who should weigh upwards of 3 kilograms. And you find here we are having intrauterine fetal growth retardation.
So at what point does this lady who comes, or woman who comes to the hospital, know that they actually have fibroids? What do you take, the procedure that you take them through?
Nowadays, we are encouraging women, especially when they celebrate their birthdays, to come for routine check. Because these are incidental findings. In many of them, you'll find that probably they had gone in because of another problem. Then an ultrasound scan, routine ultrasound scan, high resolution, picks up a uterine leiomyoma. So we are encouraging women, especially those who are asymptomatic, to come to our facilities, because currently our level 4 facilities are well equipped with high resolution ultrasound scanners. Our level 5 facility has got MRI, magnetic resonance imaging machine, and we also have CT scanners. So it's possible to pick out this at an early stage. The advantage of picking this uterine fibroid at an early stage is that it helps in prompt intervention and even the mode of management, rather than waiting for somebody to come with severe anemia requiring blood transfusion, heavy bleeding, and then will require emergency surgery. We are encouraging our women to come earlier, because when it's picked earlier, it's possible even to manage it medically using hormone modulators, as well as those who might require laparoscopic surgery. We can do that.
Now maybe someone is watching and they're wondering if they can at all get pregnant while still having fibroids.
Yes, they do. Especially these fibroids that we are talking of, subserosal fibroids. They don't interfere with the normal uterine cavity, and it is possible for a woman to carry pregnancy up to term. The only need is that they should enroll in a high risk of antenatal care clinic, where we offer focused antenatal care, and then it's possible to monitor the baby up to term. Yes.
So does it affect in any form the potential or the capability of a mother to carry this baby up to term?
Yeah, in some cases, I have just stated that you can have a problem of intrauterine fetal growth retardation. We also have problems of cord accidents as we near term, malposition and malpresentation. Those ones would necessitate, and that's why I've said this is a patient of high risk antenatal care, might necessitate delivery by cesarean section at term.
Now, you know, people who have fibroids and also experience very painful menses, as well as people who also have endometriosis. So is there a linkage between fibroids and endometriosis?
What I know is that people with fibroids tend to have heavy cyclic bleeding, that is menorrhagia. They have blood clots, huge blood clots. If they start experiencing pain, then we have to consider other factors like what you are saying. They might have adenomyosis, which means that part of the endometrial lining has grown within the uterine wall. Or they might also have endometriosis, which means that the endometrium has grown outside the normal uterine cavity. It could be in the ovaries, in the fallopian tubes, or any other part of the body. Then they have what you are describing, dysmenorrhea. Dysmenorrhea is pain during the menstrual period, that it can be very severe. At some point, some of these patients require admission because they sometimes go into vasovagal shock due to the pain. And this we see in younger women, even young teens, who have just started having their menstrual cycles. Yes. You
know, Kitambo, this was associated with the women who were at menopause, right? So what exactly has changed now that we see they can affect even the younger girls who are menstruating? Even at 9-year-olds, we see people, young girls like this, having their menses. So what has changed?
I would think, for example, the lifestyle changes that have occurred. A lot of people are consuming high-calorie diet. A lot of people are experiencing what we would call, even young girls are becoming obese. Metabolic syndrome is becoming quite common, which is associated with hyperlipidemia, glucose intolerance, and obesity. And more so in the black population, which tends to have a higher predisposition, genetic predisposition to developing the fibroids, the uterine myomas. So our community is consuming more of junk, what we refer as junk or fast foods, as opposed to in the past traditional slow foods, which had complex sugars, which were difficult to break down. Things like cassava, arrowroots, sweet potatoes, which were consumed by our grandmothers, take time to be broken down. And as a result, there was less problem of obesity. Today we see more obese women and they are the ones who are predisposed to this kind of problem of myomas.
So are smaller women safer, if at all? This is anything to go by when you say that those that have obesity are at more risk?
Among the black population, I wouldn't say they are safer, because we are also seeing diabetics who are slim, tropical diabetes. So it's about the diet. I would think that it's very important for our people to moderate their eating of fast foods, high-calorie diet at the expense of a balanced diet. Because eating food for the sake of satisfaction is not the same as balanced diet. They are missing fruits, they are missing vegetables, they are missing a lot of things in their diet. People can go even for a week without eating a fruit. And you find the same people have eaten a lot of ugali, chapati, rice. It has become our staple diet.
Yeah. And you've also mentioned that black women are more predisposed. Why is this the case? Why are we at higher risk as compared to other races?
Studies have shown there is a certain genetic predisposition, although these fibroids are mostly thought to be idiopathic, but those are the risk factors. Being a black population is a risk factor, obesity is a risk factor, as well as consumers of high-calorie diets, people with metabolic syndrome, comorbidities. They tend to be risk factors for these uterine myomas.
Now, are fibroids harmful in any way? If we are talking about, they can cause miscarriage, but are they harmful to the mother now when it's not treated?
Oh yes, I have just said that they can have severe cyclic heavy pervaginal bleeding, which will predispose them to microcytic hypochromic anemia. They will start becoming easily fatigued, and they will not be able to do their normal household chores like fetching firewood, water, taking care of their children, even performing normal duties. It becomes difficult for them to perform.
So it also causes some sort of brain fog?
Easy fatigability, that's what I have said, dyspnea, and the performance goes down. They are not able to do their routine work. Yeah.
So let's talk about the treatment. How is fibroids treated?
If they are diagnosed at an early stage, I have just said that hormones treatment can be used, medical treatment. If they are causing problems of secondary infertility, bleeders and all that, then interventions such as laparoscopic myomectomy or uterine fibroid embolization techniques are used. In women who have already had enough children, they can go for a hysterectomy.
So are there other options that are not, that aside from hysterectomy, mtu ataki kutolewa uterus, aside from the ones that you've mentioned, somebody is so scared of going for surgery, are there other options to try and stabilize?
Medical, yes. Medical management. There are drugs that are used, such as Rupride, and they do help to regress these fibroids. Yes.
Now, in a case where one has been diagnosed with fibroids, so it's not painful, they have a child, and it's something that they live with. Is it something to be stressed about, really?
No. They just need to go routinely to their doctor to be observed and to be routinely checked and to be taught about the danger signs that we have said. If they notice they're having heavy cyclic bleeding, becoming easily fatigued, unable to perform their usual duties, then they should come to the doctor.
We also mentioned in this conversation that when one is able now to conceive, they've conceived, right? And now the baby fights for space with fibroids.
Yes.
Now, if it displaces the baby, what happens to the mother and the child?
There is a high risk of intrauterine fetal death. I have also said there is a risk of cord accident, which means cord compression, cord prolapse. With malpresentation, it means the patient requires to be treated in a high, well-equipped comprehensive obstetric care level 4 facility. These are not people to deliver in smaller facilities. They should come to a hospital well equipped with emergency blood transfusion service, as well as an operating theater for emergency cesarean section. And having a newborn unit where if the baby is preterm, he can be taken care of.
You mentioned also something quite interesting, that when you have fibroids, it can cause infertility, secondary infertility. Now, surgery or treatment, I understand that sometimes inaweza kufanya mtu apate mimba. And how do you now know that one is ready to conceive after medication, of course?
Yeah, they are routinely followed up in our gynecological clinics, and we do serial ultrasound scans to check whether now they have fully recovered. And then once they have fully recovered and their cycle has resumed, their menstrual cycles are no longer heavy with pain and all that, they can go ahead and seek fertility treatment.
So fertility treatment, what does it entail really? For somebody who's watching and they have fibroids, wanataka hope, just to know that there's hope for them, they can get pregnant.
Yeah, they can get pregnant by medical treatment. That means giving them medication which boosts their fertility, which boosts ovulation, and also boosts, because we have said these ones are anemic, they also need to be put on hematinics. Because we don't want them to conceive and then the baby, because of the anemia and folic acid deficiency, develops malformations. So we routinely want them to be on folic acid, as well as careful monitoring in the gynae clinic. Those who have serious problems, there are some who may not be able to conceive, then you can consider doing in vitro fertilization.
That is IVF.
Yes, or things like intracytoplasmic sperm injection techniques. And it's also important to evaluate their spouses, because we are seeing scenarios where we think the lady has problems, but eventually you discover even the gentleman has problems, maybe low sperm count, azoospermia, which requires also to be addressed by fertility experts. Yeah.
Do you have statistics of women who suffer from fibroids in Kenya?
We cannot say, the statistics are there, but we are seeing a growing trend.
Yeah.
Like I have said, younger women coming to our hospitals, we are discovering that they have uterine leiomyomas. Those are symptomatic. So there is a growing trend of prevalence of this problem. Yeah, compared to what we were seeing in the past. In the past, it used to be a problem of nulliparous women in celibacy, like the nuns and all that. Today, even a woman who has given birth to children is presenting with the same problem. Young girls below even 20 years are also coming to us bleeding, and when you scan them, you see they're having leiomyomas. Because of what I have just said, the dietary changes. They are being introduced to high-calorie diet at a very early age.
All right, we also have a question here. We told, of course, our viewers to send in their questions. And Jen Mudhoni is asking, what if a person got a baby 8 months ago and the wound is removing usaha? Usaha. Now, na haijapona and no bleeding. What is the problem?
It is important for her to go back to the hospital to be done a check, because 8 months ago is a long period. If it was shorter, it would be puerperal sepsis. But this now is someone talking of usaha. Usaha is pus coming from the wound. Most likely she was done a cesarean section, and maybe the wound has not healed. So she should go back to the doctor to check that pus or usaha. We normally do a pus swab for culture and sensitivity to determine which bacteria is that and which drug it is sensitive to. Then she can get appropriate treatment. Yes. All
right, thank you, Jen, for that question. I hope you've gotten an answer to that. And Honorable Mausa is asking, what's the cure of fibroids, Daktari?
I've just said that these are idiopathic. What we encourage is the risk factor, to reduce the risk factors. For example, avoid a lot of junk, issues to do with obesity, go for routine checkup, and reduce taking too much of high-calorie diets.
Those permanent cures to fibroids. Now, in line with the Honorable Mouse's question, because I guess he wants to know if maybe there's a permanent cure to this.
No, I wouldn't say there is a permanent cure to them, because we have seen people who have removed fibroids and they recurred, because we say the cause is idiopathic, meaning it's not yet known. So you would have to put in the measures that we have said: dietary changes, reduce weight, go, if someone is going for routine checkup, to make sure that we identify the fibroid early, do laparoscopic surgery or give medical treatment for regression of the fibroids. And that's about it, because like I have said, this is an idiopathic problem, which when it is idiopathic, it's very difficult to say that you can cure it permanently. Yes.
All right, just hold on to that thought. We want to take a very short break at this point, Daktari. But of course, if you're watching from home, we are opening our lines to you so that you can be able to give your questions directly to Daktari. The number is just on your screen. Also send them in on our social media platforms at TV47 Kenya on Facebook and YouTube, and of course on X as well as TV47 News KE. And the number for your own benefit is 0795045864. That is our WhatsApp number. Send in your questions. We'll be back after this break.
Are you ready to elevate your business game?
As long as you're earning something, there's always that opportunity to save. And you start with where you are.
Kama wewe ni mfanyabiashara, huwezi kaa bure, unajipanga taratibu vile inavyofaa.
Join us each week as we dive into the stories of the world's most driven entrepreneurs.
When you pay attention to detail, you get luxury items.
The Grind, where business meets brilliance. Tune in every Monday at 7:30 p.m. because your business deserves the best.
Hey there friends, welcome to Kids on the Block, where fun and imagination come alive. We dive into magical world filled with exciting adventures and awesome friends.
What position were you in?
I was number 2.
What position were you?
Number 1.
He decided to cross the bridge by his house and look for food.
All right, thank you so much for staying with us. We are back, and the conversation that you're having right now on Matters Health is fibroids. Do you know what this is? And of course, send in your questions to Daktari. Daktari Stephen Gigi, Deputy Director, Medical Services, Murang'a County, is here with us. He's also a senior family medicine specialist. And Daktari, I would love to know, how many women do you operate? All right, I'm being told we have a call. Mercy, how are you? Good morning.
Morning too.
So what's your question to Daktari this morning?
Yes, nilikuwa nataka kuuliza. Daktari, nilikuwa na ectopic. Then nikaoperatiwa baadaye 5 years ago, na sijapata ball mpaka leo. Shida inaweza kuwa ni nini?
Yeah, she says she had an ectopic pregnancy and she has not been able to conceive for 5 years. And it is important for her to seek treatment in a fertility care center. If she's based here in Nairobi, she can go to Kenyatta National Hospital. There is a likelihood that the most common cause of ectopic pregnancy in women is a chronic pelvic inflammatory disease, which tends to interfere with the fallopian tubes. They get hydrosalpinx, that is fluid accumulation in the fallopian tubes with inflammatory changes. The tube tends to collapse after accumulating the fluid. And most likely she needs to go for evaluation. That will include the ultrasound scan to look and see whether the uterus is normal, the ovaries and the adnexa. They can also do a hysterosalpingogram to try and evaluate the patency of the other tube that was left after she was done, she had an ectopic pregnancy and was done salpingectomy on that other side. In the event that, they notice the other tube is blocked, she can go in for tuboplasty, which includes opening the tube laparoscopically, trying to do what we call hydrotubation and masculinization, so that she can be able to conceive. So she needs to go to either a level 4 or a level 5 healthcare facility for checkup. Yeah.
So Mercy, are you still on the line? Mercy, good morning.
I think she's watching.
All right. I hope the Dr. answer is satisfying enough for you. Maybe we'll get you back again.
Yeah.
But Dr. I was trying to get your response on this. How many patients do you operate on a daily?
We see quite a number of them in our routine clinics, in the gynecological clinics, even in our setup, a level 4 facility. We are seeing an increase and influx of patients, especially those who are delaying at home. They can see they are having heavy menstrual bleeding and they are not coming to the hospital until when their hemoglobin levels are below 6 grams per deciliter. That's when you see them being brought in the hospital, bleeding, unable to walk, severely anemic, swollen, dyspneic, and those ones now require emergency blood transfusion. So we are seeing quite a number. On average, you can find in a day we have 3 or 4 patients. And for a level 4 facility, that's a big number. Because if they will need a blood transfusion and then other interventions, it's quite a number. Yes.
So when is it time to seek for medical aid to prevent somebody waiting for them to bleed a lot for them now to come to the hospital? When is it the most exact time, ama time ile mzuri sana to look for help?
I just said it is better to come for routine checkups. We are encouraging our people to, when you walk near our health facilities, pop in for a routine scan like an ultrasound, because it can pick out other things. It's not just uterine fibroids. We have other slow, we call them silent killers like ovarian cancer, which we can pick during a routine, scan. Mammogram, we have the mammogram facilities in our level 4, but the uptake is very low. We want to encourage our women of reproductive age not to just come to the hospital because they are symptomatic or sick. Just, our women are very good in seeking health care. We would want to encourage them to come for routine ultrasound scans, mammograms. It will help us a lot to pick out a disease. We have even, I have seen in some countries like Britain, the NHS in Britain, they have mobile scanners. They are mounting it in your neighborhood where you can go, you are checked for, if there is any breast region, routine ultrasound scan. And I think we are also heading in that direction where we will have portable ultrasound scanners. And then we are able to go to the villages with our community health promoters and pick out this disease at an early stage, because the cost of treating somebody when there is a complication is much higher. Is much higher, and there is the risk of losing their lives. Yeah.
All right, remember to still call in, but when you call in, don't be scared, because there's somebody else who picks the phone call before handing it over to us. So keep them coming. We are here. Daktari is here to answer to those questions that you have. And of course, we will be sure to tackle them within this time that we have. So, Daktari, what's the size of these fibroids? What's the biggest size that you've had? Compared with, compare na nini? A ball or?
Much bigger. We see some with very huge fibroids, some weighing upwards of more than 20 kilograms. You know, those people who are walking looking like they are pregnant and the baby is not coming for years. They are supposed to come to the hospital for routine check. If you see your abdomen is growing bigger and bigger and there is no baby, then it means there is something growing there. It could be a huge ovarian cyst. It could be a huge uterine fibroid. And we are seeing them. They do come in our facilities with very big uterine fibroids, which require prompt interventions because by then they have intestinal obstruction, pressure symptoms, constipation, severe backache, low abdominal pains. They are dyspneic, and you know, they will require emergency blood transfusion.
You've mentioned something also there, ovarian cyst. What is it? What does it entail?
This is a swelling. It's an abnormal swelling of the ovaries. The most common ones are simple, cystic, with a clear fluid inside. We also see cystadenomas, and in some cases we see mucinias, cystadenomas, and cyst adenocarcinomas in some patients. Those are the patients who I said sometimes they have what we call ovarian cancer, which is a silent killer, because they will have, the symptoms are not very clear. They will just present with abdominal fullness, easy satiety, they don't feel like eating a lot. Sometimes they are on antacids, and then eventually you discover, when you scan them, you find they have already developed ascites.
Just hold on, kidogo, Daktari, we'll recap on that. We have Mary. From where, Director, if you could remind me? From Mukubu is on the line. Good morning, Mary. How are you?
Yes, hello.
Hello, good morning.
Good morning.
So what's your question to Daktari, Mary?
Okay, I'm Nancy, nimetoka Meru.
Yes, we can hear you.
Good morning.
Good morning, we can hear you clearly.
Okay, nimetoka Meru. And kuna swali. I have a sister. Amekuwa infertile for, yes? Hello?
Yes, Mary.
Sistangu amekuwa infertile for more than 7 years. So amechukua dawa na hospitali for the last 5 years. Jack ameambiwa the shida iko kwa fallopian tube. Hello?
Mary?
And then amechukua dawa but no feedback, hajapata menstrual bado. So nilikuwa nauliza daktari shida ingekuwa ni.
Daktari, have you gotten Mary clearly?
He's talking of somebody who is unable to conceive, yet they have normal menstrual periods, cycle, and flow, and for 7 years. And these are the patients I'm saying they should go to the hospital. I have observed people wait for too long to go to level 4 or level 5 facilities or to seek fertility treatment. We have assisted reproductive technology in this country. So it is important. She says he's in Meru, so she can still go to Meru level 5 or even come here at Kenyatta National Hospital in the fertility centers so that they can evaluate and see, because we have people, even with normal menstrual cycle, who are unable to conceive. And she should be accompanied by her partner, because sometimes the we are leaving the burden of proof to the lady, but probably the man should be evaluated. I've just said that we are also seeing a rise in case of male azoospermia. Men who are unable, with low sperm counts because of also increased consumption of alcohol, tobacco smoking. It tends to lower the sperm count. So it is very important that they both go for evaluation as a couple. Routine seminarities can be done for the man. They can also do the scans for the lady, the hysterosalpingogram and all that. Hormonal, profile can be done. And then appropriate treatment can be given. If it's medical treatment, it's okay. If it requires assisted productive technology, including in vitro fertilization, or what we talked about, intracytoplasmic sperm injection techniques, it can be done. Or artificial insemination. Yeah.
Mary, are you still on the line? All right, we also have Sheila on the line. Sheila, good morning. How are you? All right, we've lost Sheila. But Dr. before Mary's call, we were talking about the sizes of these fibroids. Maybe you can pick that up again.
Yeah, I was explaining that they can grow exponentially, and some patients present to us with a fado height of 36 weeks, looking like a term baby. Because, like I said, maybe that is the only symptom they have is their swelling. They are not feeling pain. The body has adjusted itself, so even when they are anemic, you will find women with very low HB still being able to walk in the market and to do their normal household chores. The only problem now is if a comorbidity arises, because chronic anemia predisposes to low immunity and risk of other infections increase. So they will come to the hospital probably because they have other infections, and during the routine check, you discover that they have these very huge fibroids. And a lot of them are taking their time. Even after you diagnose they have those huge ones. They still, some are nulliparous, they have no child, and they will still tell you that they need to be given time. Others are going to be prayed for. They go look for somebody to pray for them, and they believe that the fibroid will disappear. So we are dealing with a lot of issues here.
So
yes.
when a patient comes to you and they say they're taking their sweet time.
Yes.
You ask them, of course, why don't you want treatment? So what's their response?
I see them even being brought by their relatives, their brothers, their sisters, because the family is concerned. They can see somebody is very sick. They can see somebody's abdomen is swelling a lot. She's requiring frequent blood transfusions. But, we give information, and then they have to give the consent for treatment. So it's still up to the patient to decide what should be done to them, because these are adults. Yes.
So what's the side effect of staying with this for too long? Now that Kienda home, she's too comfortable with it.
Of course, if it is the main cause of the secondary infertility, she may not be able to conceive. And if she conceives, she might have recurrent miscarriages and pregnancy losses. The risk of severe anemia requiring frequent transfusion. If she gets another comorbidity, another lifestyle disease, then she's at a higher risk of complicating. If she gets diabetes, because we have said that a number of these people are obese, they have got metabolic syndrome, hyperlipidemia, they are predisposed to hypertension and diabetes. So waiting, once we see one disease, we actively look for other comorbidities. Yes.
So, Dr. there's a lot of stigma surrounding fibroids as well. People don't talk much about it.
Yeah.
Why is this the case?
Many illnesses, people have, put that element of stigma. But we are encouraging our people. That's why we are putting in community health promoters. We have got ambassadors. Those are our ambassadors in the community to talk and actively engage the people to be going for routine checkups for diseases. People are not accepting they have hypertension, even diabetes. They come to us and they will tell you, there was once I was diagnosed with hypertension, but I'm now okay. They will come, and we know these diseases are chronic. They will come, and I see a lot of them in our family medicine clinic. They will come and tell you, there was a time I was told I am diabetic, but I think I took some herbal medication or something and I'm okay. There is that tendency for people to assume that some of these chronic diseases are curable. So it is important for people to know that these are diseases we have to live with. We have to routinely go for checkups and treatment, and that's why our government has put more doctors at level 4s and level 5 facilities to handle this, and that's why we are having more community health promoters. The idea of the community health promoter is to pick out this diabetic who is not coming to hospital. Pick out this obese patient who might get hypertension and get a stroke in the village. Pick out this lady who has a big tummy and is not giving birth. Bring them to the hospital, and then we are able to scan and see it is a huge fibroid and give appropriate treatment. So it's actually bridging the gap between the care provider and the community, making it easy for these people, because in the past it was very difficult to access such services, but now we have them. I've just said it is the uptake of routine checkups and screening that we are scaling, so that we don't have a lot of people all of a sudden coming to us with complications of even cancer, treatable diseases which we could have treated at an early stage at a lower cost.
And is this the reason as to why, you know, we didn't used to talk much about fibroids? This is something that we've started talking much about just recently. Is it because we were not much exposed to these topics? Is that the reason? That
could be part of it, public health education, which we have done a lot. The other one was the availability of equipment to screen, which we have now. The involvement of community health volunteers, promoters, who are able to encourage people, because they are able to interact people in the chamas at the community level, and encourage these women to come to us for routine check. We do outreach services where we normally go to villages and even churches and educate people and also screen them for lifestyle diseases. So it is about awareness, creating more awareness, picking out the disease at an early stage, and prompt intervention so that we don't incur a lot of unnecessary costs. Yeah.
And you know, we hear more about fibroids being hereditary. It's much about genetics. So maybe you can tell us the link between this.
Black population, studies in the US have shown more of the black population have a predisposition to developing fibroids. But like I said, the condition is idiopathic. Idiopathic means it is of no known etiology. No one knows what actually brings in the fibroids. But the risk factors that seem to be associated with this include lifestyle, behaviors to do with diet, a lot of junk and a lot of high-calorie diet, obesity, weight gain, and those are the things. Yeah, but we usually demystify the myth that people try to associate with the use of family planning methods.
Yes.
There is no relationship between that and uterine fibroids.
Yeah.
Yes.
So when they say that maybe contraceptives can cure it, or contraceptives actually bring fibroids, that's a myth.
They help. Actually, the hormones help. They will help to regulate the menstrual cycle, prevent this unnecessary bleeding and anemia. They do help, and then medical therapy also helps to regress, to try and help this fibroid to shrink, in layman's language, to shrink so that it does not cause infertility and the other symptoms of bleeding and pain.
Doctor, we have a call for you from Alice. Alice is in Kangwere. Good morning, Alice.
Good morning, I'm Alice.
Good morning.
Hello?
Yes. Good morning, I can hear you.
I wanted to ask, once you are done surgery, is there a possibility of recurrence? And after the surgery, is there a specific food maybe you should be taking?
Yes, there can be a possibility of recurrence, and that's why you need, even after the surgery, you need to be followed up in the gynae clinic. And also, most of the time, women want to remove these fibroids because of the issue of fertility. So they also need to be followed up in the fertility clinic so that the appropriate investigations can be done to ascertain whether they are now they can be able to conceive. Yeah, the routine checks, the routine ultrasound scans to assess the uterus and see hormonal profile and all that, hemoglobin level, so that we prepare these women to conceive. Like I said, quite a number of them are anemic and they need supplementation of folic acid and even iron, so that when they conceive, the baby will not have problems of malformations. Neurotube defects are quite common with the folic acid deficiency. And that's why the government gives it as a routine to all pregnant women in form of IFAS. I think you have heard of that. The problem we see is that our women normally come to the antenatal care clinic when everybody can see they are pregnant. They are supposed to come even before they conceive for preconceptional counseling and care, so that they are educated on the danger signs and all the symptoms, and then prepared adequately so that during the whole conception, the baby, the fetus is not predisposed to malformation. Because we are also seeing a rise in babies with malformation.
All right, Alice, are you still on the line?
Yes. After how long should you be going for the checkup?
Usually, immediately after you have been done the operation, when they are discharged, it's good to be seen within a fortnight, that's around 2 weeks, by the doctor who has treated the patient, so that they can walk the journey together. They can be evaluated, the wound, like we talked about here, that somebody can have post-op sepsis, the wound is discharging, then the pus can be taken in the laboratory for microscopic culture and sensitivity, and appropriate antibiotic therapy given. Then once the wound has healed, it is important for them to continue seeing the doctor, even if they are not having any pain, because of the routine tests that we have said, including the ultrasound scan, hormonal profile, full hemogram, all that, to ensure that they are now healthy enough to move to the next level of conception.
Alice, are you satisfied with Dr. answer? All right, thank you so much, Alice, for that. Now, you were telling me something about the relationship between genetically, the relationship between fibroids and genetics, Doctor.
Yes. I was explaining that it is an observation that researchers have made that black population tend to have a higher predisposition to uterine fibroids. But also another observation about obesity, that the black population also tend to have more obese people. If you check, mostly in these studies were done in the United States. The black population has also been shown to have more of metabolic syndrome, which is hyperlipidemia, glucose intolerance, meaning that if you check their routine blood sugars, they are always somewhere in the ranges of between 7 and 11 millimoles per liter. WHO will recommend that you don't have, when you are in that stage, it is called prediabetes. Routine sugars that are ranging in the ranges of 8, 9, and 10, it means somebody is walking towards diabetes type 2. And these are the people now we are also seeing coming with a comorbidity of uterine myomas, the obese ones. So there is that element, and the studies are still ongoing to see what can be done.
All right. Of course, as we wind up, a quick recap for treatment. There's treatment, right, Daktari, for this. Ultrasounds are recommended every now and then. Severe menstrual pain should be a sign to look out for. and you can get pregnant if you are worried about that. So Daktari, of course, as we wind up, anything, any advice, any word of hope for somebody with fibroids or for women watching?
Yes, there is a lot of hope, and our men should take their lead. Bring that sister of yours, bring that daughter of yours, bring that spouse of yours for routine check in our level 4 facilities during the celebration of their birthdays. A lot of them put on social media huge cakes which they eat. I think you can make half the cost of that cake, and then the other half can come and cater for routine ultrasound scan to keep that person healthy, because a number of people we are discovering have serious problems when they go for routine checkup. When we offer outreach services, that's where we are picking out those diseases. They are silent killers, and we mean silent because they are painless initially. The patient is just routine living normally, and then you hear suddenly somebody has complicated and is in hospital, even we lose them. So the earlier they come, the better. We are emphasizing primary health care, preventive care, routine checkup is the key. Yeah.
All right, thank you so much, Dr. Stephen Ngegi, Deputy Director, Medical Services, Murang'a, a Senior Family Medicine Specialist, for the great insights that you've given us this morning. And of course, even as you're watching at home, thank you so much for your feedback, for your questions. We truly appreciate it. Up next is Fitness Thursday. Stay with Morning Cafe.